The topic of discussion in this session will be the large intestine. First, we see the anatomical position of the large intestine. This is how you hold it in the anatomical position, with the cecum appendix on one right side and the sigmoid colon on the lower left side, and the transverse colon hangs down in the middle. And from the hand positions you can see the hepatic flexion of the colon and the splenic flexion of the colon, which is a bit high than the hepatic flexion. The large gut extends from the ileocecal junction to the mucocutaneous junction of the anal canal or the pectinate line. It is about 1.5 meters or 6 feet long. It is subdivided into 4 parts: cecum and appendix, colon, of which 15 centimeters is ascending colon, 50 centimeters transverse colon, 25 centimeters descending colon, and 40 centimeters sigmoid colon. Rectum is 12 centimeters, anal canal is 3.8 centimeters. There are certain features, characteristic features of the large gut. They need to be remembered. It presents 3 cardinal features called tinea coli, sacculations or ostrations, and appendices epiploidy. Now, one by one, we will see them in this specimen. Coming to the tinea coli at first. The tinea coli are 3 thick bands produced by the aggregations of the longitudinal muscles of the large gut. A thin layer of longitudinal muscle is, however, present between the tinea as well. The tinea are absent in the vermiform appendix and in the rectum. Each tinea coli is about 4 feet long. Within the 4 feet tinea, a large 6 feet large gut is inserted. Therefore, the surface of the large gut is sacculated or ostrated. In a vertical colon, that is cecum, ascending, descending, and sigmoid, the positions of tinea coli are as follows: tinea libera on the anterior surface, mesopolica on the posterior medial surface, and ommentalis on the posterior lateral surface. In the transverse colon, the tinea libera lies on the inferior surface. Now, here we are seeing the tinea libera on the inferior surface, tinea mesopolica on the posterior surface along the attachment of transverse mesocolon, and tinea ommentalis on the anterior-superior surface along the attachment of the posterior 2 layers of the greater omentum. So, once again, can we have a recap of these 3 layers? In transverse colon, tinea libera lies on the inferior surface, tinea mesopolica on the posterior surface along the attachment of transverse mesocolon, and tinea ommentalis on the anterior superior surface along the attachment of posterior 2 layers of greater omentum. Right? Traced proximally, all tinea converge towards the base of the appendix. So, there is the appendix. They all converge towards the base of the appendix. Traced distally about 5 centimeters above the rectosigmoid junction, the tinea unite to form 2 thick bands. The anterior band passes in front of rectum and is formed by the fusion of tinea libera and tinea ommentalis, whereas the posterior band passes behind the rectum and is formed by the continuation of tinea mesopolica. As evident, sacculations or ostrations are present where tinea coli exist. Coming to the next point, appendices epiploidy. These are peritoneal pouches containing fat and are present in the entire large gut except cecum, appendix, and rectum. Now the appendices are most numerous in the transverse and sigmoid colon. They usually project between the tinea libera and the tinea mesocolica. Cecum and appendix has been dealt separately in a separate video. We will shift our focus directly on the ascending colon. The ascending colon is about 15 centimeters long and 5 centimeters in caliber. It extends upwards as a continuation of the cecum from the transtubercular plane to the right colic flexure, where it turns to the left and is continuous with the transverse colon. The right colic flexure is situated about 2.5 centimeters below the transpyloric plane and 10 centimeters to the right of the midline. The ascending colon lies just outside the right lateral plane. Tinea libera lies in front, tinea mesocolica on the posterior medial surface, and tinea ommentalis on the posterolateral surface of the ascending colon. Appendices epiploici are found on the anterior surface between tinea libera and mesocolica. The anterior surface and the sides are covered with peritoneum. However, the posterior surface of the ascending colon is non-peritoneal and is related to the fascia iliaca covering right iliopsoas muscle, iliolumbar ligament, quadratus lumborum, and the anterior layer of thoracolumbar fascia. It also comes in relation to the right fourth lumbar artery, ilioinguinal, iliohypogastric nerves, subcostal vessels and nerves, lower pole of right kidney. Okay, coming to the next part, the transverse colon. It extends across the abdominal cavity from the right colic flexure to the left colic flexures and describes a curve which is convex downwards and forwards and is suspended from the posterior abdominal wall by a peritoneal fold, the transverse mesocolon. It measures length of 50 centimeters, breadth 5 centimeters close to the right end and 3.5 to 4 centimeters close to the left end. Coming to the presenting parts of the transverse colon presents right colic flexure, colon proper and the left colic flexure. The right colic flexure is the junction of ascending and transverse colon and is situated in the right lumbar region. Topographically, the flexure is represented by a point about 2.5 centimeters below the transpyloric plane and about 10 centimeters to the right of the median plane. The colon proper extends from the right colic flexure medially for about 5 centimeters. Between the head of the pancreas and the lateral end of the spleen, it presents a V or U-shaped loop which extends downwards and forwards to the umbilical or the hypogastric region. The loop is suspended from the anterior border of the body of pancreas by the transverse mesocolon. Close to the lateral end of the spleen, it bends abruptly downwards and backwards and is continuous with the descending colon at the left colic flexure. Coming to the left colic flexure, which is also known as the sphenic flexure, it is the junction of the transverse and the descending colon and situated in the left hypochondriac region. Topographically, it is represented by a point about 2.5 centimeters above the transpyloric plane and 10 centimeters to the left of the midline. Left colic flexure is more acute, more deeply placed and lies at a higher level than the right flexure. It is suspended from the diaphragm by a triangular peritoneal fold known as the phrenico-colic ligament, which passes below the lateral end of the spleen and supports the spleen from below. Now these are the very important points with regard to the transverse colon. A few words need to be mentioned regarding the transverse mesocolon, which is a broad peritoneal fold which suspends the transverse colon from the posterior abdominal wall. The transverse mesocolon consists of two layers. In early life, both layers are derived from the greater sac, but after puberty, due to zygosis, upper layer is derived from lesser sac and the lower layer from the greater sac. Now we won't go into details of the transverse mesocolon description. We will end our discussion on transverse mesocolon with a brief note on the contents of the transverse mesocolon, which are the transverse colon, anastomosis between middle colic and ascending branch of left colic vessels forming marginal vessels of Drummond, nerves and lymphatics supplying the transverse colon, and loose areolar tissue and some amount of fat. Next we will shift to the description of the descending colon.